Okay, we're now live. Hey, everybody. Today is May 8th, Thursday. I think it's a beautiful day out when I was out early this morning, so it's getting nice. Well, of course, it's May. Um, what else is happening? We're doing a bunch of stuff on CTisus. We're getting some new lectures I'm preparing, some new apps we're updating and changing, and lots of new cases, material. Lily's been working very hard, doing a great job on all of those meta pearls that you get, those topics. So that's going along well as well. We did have a guest speaker this week, a friend of mine, Kimberly Powell, who's head of healthcare for NVIDIA. She spoke here in 2018, so that's 7 years ago. We were commenting how much AI had changed, where in that meeting, she spoke about how AI was going to change medicine and drug discovery and radiology and improve care for patients. You fast forward 7 years, AI is what's driving all of patient care. It's being used in most places to some level. Every pharmacy company is using AI to discover new drugs, and the opportunity for better patient care, earlier detection, better monitoring, better outcomes is really what AI is about. So Kimberly also took us to look at agentic AI and physical AI, all the robotics, all the things, doing ultrasound with a robotic arm, all of the things that you think about or don't think about are happening, and we'll have a good article in JCR hopefully soon on that, and you can read it then. But it's really amazing. I cannot tell you how impressive it is. You also realize how much you would like to learn and how much you would like to know. There's so much to learn and so much to know, but there's so little time, right? Everyone's busy. You read the numbers about how short people are in radiologists, like whole countries. I mean, I'm calling Hawaii a country, but they're backed up 8,000 or 10,000 films. You just can't get the work done. And unless AI gets much better or becomes more mainstream, I think AI is making things more efficient, but it's hard as the volumes keep going up 5 to 10% a year, because imaging is so critical, and the growth is on CT, MR, ultrasound. Growth is really everywhere. But the growth of radiologists is very flat unless the president can negotiate a deal where someone ships us a bunch of radiologists as if they were shipping cars. Well, nothing's going to change for a while, so I don't have a great answer, and we won't even discuss that. We're going to discuss the bladder. So let me just tell you a few things about the bladder. Bladders are most CTs of the abdomen. We do dedicated bladder studies, bladder cancer staging. We look for fistulas to the bladder in patients with complications of surgery or diverticulitis or cancer. We look at the bladder in terms of potential infection. We talk about things like emphysematous cystitis. We talk about, I mentioned cancer. I showed you a great case of myoma a couple of weeks ago, but mainly it's cancer. So what I'll just talk about in the limited time we have is protocols. Now, if you ask me if you're looking for hematuria, we always scan from diaphragm to symphysis. It's good to give the patient a couple cups of water before they start. It distends the stomach, but also causes excretion of urine, and so the bladder is better distended. You don't want the patient to go to the bathroom right before the CT scan. The way we pick up early tumors, often incidental, is areas of subtle enhancement in the patient's bladder wall. If you see a focal lesion, even if it's 4 or 5 millimeters and it's enhancing, it's a cancer. So we can pick up incidental cancer. We can pick up cancers that are bleeding. Obviously, a larger cancer you can pick up early phase, late phase, whatever you want, but it's really that early arterial phase that helps you pick up small tumors, and we've written about that. So the tumor enhancing to about 90 Hounsfield units against the patient's urine, which is about 0. If we're looking for a fistula between the colon and the bladder, you could do a CT cystogram. You put a tube in the bladder, You drip in 500 cc's of contrast, 30% via gravity. However, I think if you're looking for colovesical fistula, you probably do better by giving rectal contrast, because you can give it with force and the rectal contrast will extend into the bladder and define the fistula. Again, post complications of surgery, cancer, diverticulitis, trauma are all some of the possibilities. So colovesical fistula, giving IV contrast, getting delayed scans is not going to help anything. The other thing are CT cystograms. If you're worrying about bladder trauma, you have pelvic fractures, but you don't see a bladder injury, if you just have contrast from above and it fills in the bladder, it doesn't exclude a bladder injury because it's not distending the bladder, and you can miss a bladder injury. If you have the type of trauma, like pelvic fractures and the like, where you're really worried about bladder injury, you do a CT cystogram. 500 cc bag of contrast, 500 cc bag of saline, 50 cc's of contrast, shake it under gravity, push it in the patient's bladder, and that will pick you up all of the bladder injuries. So again, a CT cystogram is critical for bladder trauma. Just waiting for the bladder to distend, and even if it distends, it looks normal, is not going to exclude a bladder injury. So protocol there becomes very important. And again, you want to take a look at the bladder on any trauma patient, but especially a trauma patient who has pelvic injuries, particularly symphysis injuries. And the more injuries you have in the pelvis, the more likely there is to be bladder injury. Look at the prevesical space, pelvic sidewalls, see if you can see any blood, and then you might infer there could be a bladder injury, and then you do the CT cystogram. And I think the clinicians also do understand that. In terms of the bladder, if you have a mass that's enhancing, think of pheochromocytoma. The bladder is one of the sites for extraadrenal pheochromocytomas, which are often called paragangliomas, but they're just smooth masses, but they enhance brightly. Smooth masses, the bladder wall, leiomyoma. We had a case I showed in conference yesterday of a big bladder mass, and it was a extramedullary from myeloma, where the mass grew into the bladder wall. So it was a very impressive case, very nice involvement. You can see lymphoma of the bladder by direct extension or diffuse infiltration of the bladder wall. And again, in trauma patients, look very carefully. Again, bladder is not well distended. You just can't make the assumption the bladder is fine. And the patient may not have hematuria, because if you have injury to the ureter, you may not have any hematuria. So again, very important to look at that. And I think that's where I'll stop. I'm putting together a talk again, a new talk on the bladder. I'll go through a lot of those things. If you go to CTisus website, under teaching files, there's bladder stuff, a lot of bladder cases you can look at, a bunch of protocols and everything else. So with that, I'll just wish everybody a good day, and I hope everybody is doing well. Have a great day, everybody.